Let me ask you something direct. If you take a pill every single morning for your blood pressure, can you actually answer this question? Why that specific one and not one of the other two main options? Most people cannot. They were handed a prescription, told it lowers blood pressure, and sent home. That was the entire conversation. Here's what almost nobody explains afterward. There are three completely different families of blood pressure medication in common use. Each one works through a different mechanism inside your body. Each one carries a different set of risks that grow specifically with age. And the fatigue, the dizziness, the swollen ankles, the dry cough that will not quit, these are routinely dismissed in a 10-minute appointment as simply getting older. In a significant number of cases, it is not age, it is the medication. And the reason this matters so much after 60 is specific and physiological. Not a guess, not fear-mongering, a documented mechanism we are about to walk through in full. 6 things. Every one of them something your next appointment will not have time to cover. Subscribe to Dr. Sam Sterling and leave a like before we continue. If you or someone you love takes amlodipine, Losartan, or Lisinopril, what you hear in the next 20 minutes could change how that medication is monitored going forward. These 3 medications save lives. That is not in question and never will be. What is in question is how completely they are explained when they are prescribed, and how thoroughly they are monitored once a patient passes 60. A 10-minute appointment was never built for that conversation. This video is. Before we get into the 6 things, you need one framework that makes every single point that follows make sense. Call it the chart versus the body problem. Your doctor looks at a number. Blood pressure, 124/78. The number looks correct. The chart says success. But the chart cannot see that. You are dizzy when you stand. The chart cannot see that you fall asleep mid-sentence by 2 in the afternoon. The chart cannot see your ankles swelling against your shoes by evening. A number on a chart and how a body actually feels living with that number are 2 completely different pieces of information. And after 60, the gap between them widens. Because the dose that was calculated using research on younger adults is now being processed by a body that metabolizes medication differently, clears it through kidneys that work less efficiently, and has less physiological reserve to absorb side effects quietly. Keep that gap in mind through everything that follows. The number can be perfect. The body can still be paying a price nobody is tracking. There is a reason that gap specifically widens after 60, and it comes down to 3 measurable changes in how your body handles medication compared to when you were 45. The first is kidney clearance. Most blood pressure medications are removed from your body primarily through the kidneys. Kidney function declines gradually and predictably with age. By your 70s, filtration capacity is commonly reduced by 30 to 50% compared to your 30s, even with no diagnosed kidney disease at all. A dose calculated to clear your system in 24 hours at age 50 may now be clearing far more slowly, meaning the medication is accumulating to a higher effective level than your prescription was ever designed to produce. The second is body composition. As we age, the proportion of body fat increases, and the proportion of body water decreases, even at a stable weight. Several blood pressure medications, including calcium channel blockers like amlodipine, are fat-soluble, meaning they distribute differently through a body with a higher fat percentage. This can extend how long the medication remains active in your system, well beyond what the original dosing studies anticipated, since those studies were conducted primarily on younger bodies with different composition. The third is baroreceptor sensitivity. Baroreceptors are pressure sensors located in your major arteries that detect blood pressure changes and instruct your heart and blood vessels to compensate instantly, for example, when you stand up. After 60, baroreceptor sensitivity declines measurably. This is the direct physiological reason that orthostatic hypotension, which we will cover as one of the 6 things on this list, becomes dramatically more common and more dangerous specifically in this age group. The same medication, the same dose, produces a slower, weaker compensatory response in an older cardiovascular system. These 3 changes do not mean these medications are unsafe. They mean that a dose and a monitoring schedule appropriate at 50 may need genuine reassessment at 70. And that reassessment is precisely the conversation most patients never have. Number 1. 3 drugs, 3 completely different mechanisms, and why that distinction actually matters. Walter Higgins is 70 years old, a retired high school shop teacher from outside Tulsa, Oklahoma. At a routine checkup, his blood pressure came back elevated. His doctor wrote a prescription for amlodipine and said, "Take this every morning." Walter asked what it actually did. The answer he received was 4 words. "It lowers your pressure." Walter took that pill daily for 3 years without understanding the mechanism behind it, what else it might be doing to his body, or why this particular drug had been selected over the alternatives. Here is what Walter was never told, and what a significant number of patients are never told either. These 3 medications are not interchangeable variations of the same idea. They work through entirely different biological pathways. Amlodipine belongs to a class called calcium channel blockers. Relaxes the smooth muscle lining your blood vessel walls by limiting calcium entry into those muscle cells, allowing the vessels to widen so blood moves through with less resistance. Losartan belongs to a class called angiotensin receptor blockers, often shortened to ARBs. It works by blocking the receptor that a specific hormone, angiotensin II, uses to signal blood vessels to constrict. Block the receptor, and the constriction signal cannot land. Lisinopril belongs to a class called ACE inhibitors. Rather than blocking the receptor, it prevents the enzyme that produces angiotensin II in the first place. Different point in the same pathway, different mechanism, different downstream effects. This distinction is not academic trivia. Each class carries a distinct side effect profile, a distinct set of drug interactions, and risks that shift in different directions as kidney function and vascular elasticity change with age. Knowing which class you are on, and why that specific class was chosen for you, and not one of the other 2, is the single most important piece of information missing from most prescriptions handed out today. Your first action step. At your next appointment, ask this exact question. Why was this specific medication chosen for me instead of one of the other 2 classes? If the answer is vague or generic, that is worth pursuing further, not accepting as final. Number 2. The swelling your doctor calls harmless, that genuinely is not. Eleanor Pruitt is 74, a retired church choir director from a small town outside Spokane, Washington. She has been on amlodipine for 5 years. For most of that time, her ankles have been visibly swollen, not slightly puffy, swollen enough that she stopped wearing the dress shoes she had worn comfortably for decades. She mentioned it to her doctor on 3 separate visits. Each time the response was the same 3 words. That is normal. She adjusted. Wider shoes. Feet propped up most evenings. She accepted it as the price of the medication, until a routine visit to a podiatrist for an unrelated issue led to a referral for a full vascular workup, which found that the swelling had been masking a slowly worsening circulatory problem for well over a year. This is far from rare. Documented research places amlodipine-related peripheral edema at up to 10% of patients on the medication, with incidence climbing meaningfully with both age and dose. In routine care, it is frequently waved away as cosmetic. It is not. Here is the actual mechanism. Calcium channel blockers like amlodipine widen arteries more than they widen veins. That mismatch causes fluid to leak out of the smallest blood vessels, the capillaries, into the surrounding soft tissue. In a younger body, compensatory mechanisms absorb that imbalance reasonably well. In an older body, where venous return is already less efficient, the imbalance compounds. Swelling reduces mobility. Reduced mobility further slows circulation. Slower circulation increases the risk of falls. That chain is not harmless. If you experience swollen ankles on a calcium channel blocker, do not simply accept the explanation that it is expected and unimportant. Request a full medication review. Alternatives genuinely exist. Switching to an ARB, adjusting the dose, or combining a lower dose with a second medication class can often resolve it. Never let normal be the final word when a side effect is visibly changing how you move through your day. If swelling from a blood pressure medication is something you or someone you love has experienced, type swelling in the comments. I read every one. Number 3. The cough that will not stop, and what it is actually telling you. Bernard Okafor is 67, a retired postal sorting supervisor from a suburb of Cleveland, Ohio. Roughly 3 months after starting Lisinopril, developed a dry, persistent cough. Not a cold. Not seasonal allergies. A tickle at the back of his throat that escalated into a cough that simply refused to resolve. He saw a pulmonologist. He had a chest x-ray. He spent more than one night quietly worried it might be something far more serious. For 8 months, across multiple medical visits, not a single clinician asked him the one question that would have solved the mystery immediately. What medications are you currently taking? This is not a rare reaction. ACE inhibitor-induced cough affects up to 15% of patients on this medication class, and some population studies place that figure even higher. The mechanism has been extensively reviewed in major medical literature. Lisinopril works in part by blocking the enzyme responsible for breaking down a compound called bradykinin. When bradykinin is not broken down at the normal rate, it accumulates in lung tissue, irritating the airways and triggering a persistent dry cough that no amount of cough syrup will touch, because the cause has nothing to do with infection or allergy. In older adults specifically, this cough is more than an irritation. It disrupts sleep. It can trigger brief dizziness during coughing fits. It increases fall risk during those episodes. And it quietly erodes quality of life in ways that are difficult to quantify, but easy to feel. If a new, unexplained cough developed after starting an ACE inhibitor like Lisinopril, raise it with your doctor directly and promptly. Switching to an ARB such as Losartan resolves this cough in the vast majority of cases. This is a well-documented, well-understood, entirely solvable problem. It should never be something you are told to simply live with. Number 4. The potassium problem that almost nobody is actively checking. I am not going to anchor this one to a single patient, because the broader clinical data tells a more urgent story than any individual case could. Both ARBs like Losartan and ACE inhibitors like Lisinopril share a well-documented effect that receives far too little attention in routine care. They can raise potassium levels in the blood. The clinical term is hyperkalemia, and research published in major kidney disease journals shows that hyperkalemia-related hospitalizations among older adults taking these medication classes are both common and rising. The mechanism is specific. These drugs reduce the activity of a hormone called aldosterone. Aldosterone's job is to signal the kidneys to excrete potassium. Less aldosterone activity means less potassium leaves the body through urine. Now layer on the reality of aging. Kidney function naturally declines over time, which means the kidneys are already working with reduced capacity to clear potassium, even before the medication is factored in. Then layer on diet. Many seniors are actively encouraged to eat potassium-rich foods for heart health: bananas, spinach, potatoes, sweet potatoes, beans. All genuinely heart-healthy, all also high in potassium. Then add potassium-based salt substitutes, frequently used by health-conscious adults trying to reduce sodium intake without a second thought about potassium load. The accumulation can become dangerous, and here is the part that concerns me most, as someone who explains this for a living. Hyperkalemia frequently produces no symptoms at all until it triggers a serious cardiac arrhythmia, a dangerous disruption in heart rhythm, with little to no warning beforehand. If you are on Losartan, Lisinopril, or any medication in the ARB or ACE inhibitor class, potassium levels and kidney function should be checked regularly, at an absolute minimum every 6 months. This is not optional monitoring. It is essential. At your next visit, ask one direct question. When was my potassium last checked? If nobody can give you a clear, specific answer, that gap needs to close immediately. If you have been on one of these medications for over a year and have never had potassium levels tested, type "never" in the comments. You may be surprised how many other people watching are in the exact same position. If you are still with me, tell me in the comments which of these 3 medications you or someone in your family currently takes. I read every single comment, and it genuinely shapes which topics I cover next. Number 5. The blood pressure reading that looks perfect on paper and is quietly the most dangerous number on this list. Agnes Whitcomb is 77, a retired hospital administrative assistant from a suburb of Hartford, Connecticut. Her blood pressure consistently read 116/72. Her doctor described it at every visit as beautifully controlled. Agnes took pride in that number. But Agnes had started falling. Once near the kitchen counter, once in the garage, scraping both palms badly enough to need bandaging. Then, one morning, her son found her on the bathroom floor. She had stood up quickly, the room had gone dark, and she had gone down. The emergency department diagnosis was orthostatic hypotension. Her blood pressure was dropping sharply every time she stood, faster than her circulatory system could compensate. The exact medication protecting her heart on paper was simultaneously placing her bones and her brain at direct risk. The clinical evidence behind this has grown substantially. Follow-up analysis from the landmark SPRINT trial, alongside a widely cited 2023 study published in JAMA Internal Medicine, found that intensive blood pressure lowering in adults over 75, pushing systolic readings below 120, was associated with significantly higher rates of falls, fainting episodes, acute kidney injury, and dangerous shifts in blood electrolytes. In response, major geriatric medical bodies have recommended more relaxed blood pressure targets for many adults over 75, suggesting that a systolic reading closer to 150 may in fact be more appropriate for patients managing multiple health conditions simultaneously. Walk through the actual cascade with me, because this is the one I most need you to fully absorb. Medication lowers blood pressure aggressively. You stand up from a chair or rise out of bed. Blood pools in the legs because the vessels cannot constrict quickly enough to compensate. Blood flow to the brain drops momentarily. Dizziness hits. Vision dims briefly. You reach for something to steady yourself. Sometimes you miss. A fall follows. Sometimes a hip fracture follows that. Surgery. A hospital stay, where hospital-acquired complications are a genuine risk. Extended immobility. Then muscle loss, cognitive decline, and often depression on top of all of it. One number on a chart, perceived by everyone in the room as unambiguously good news, can be the first domino in that entire sequence. Here is what to actually do. Ask your doctor specifically to check your standing blood pressure, not only your seated reading. Request orthostatic vitals, blood pressure measured both lying down and standing, at every single appointment. And have a direct, honest conversation about whether your current blood pressure target is genuinely appropriate given your age, your fall history, and your overall health picture. A systolic reading of 140 may be authentically safer for you than a reading of 116. The lowest number is not automatically the best number. Number 6. The 5 questions worth bringing to your next appointment. This is the part I want you to actually keep. Screenshot it, write it down, print it if you need to. These 5 questions can meaningfully change how your blood pressure is managed going forward. Question 1. Why am I on this specific medication and not one of the other 2 classes? You are entitled to a specific answer, not a generic one. Why amlodipine over Losartan? Why Lisinopril over an ARB? The reasoning should reflect your particular health picture. Question 2. What is my blood pressure when I am standing, not only when I am seated? A seated-only reading shows half the picture. The other half could prevent a fall. Question 3. When were my potassium and kidney function last checked? If you are on an ACE inhibitor or ARB, and this has not been monitored regularly, that is a gap in your care that needs closing without delay. Question 4. Is my current blood pressure target genuinely appropriate for my age and overall health? The correct target for a 55-year-old is not automatically the correct target for a 78-year-old. This question opens a conversation many doctors will not initiate on their own, but will respect being asked. Question 5. Are any of my other medications or supplements interacting with this one? Blood pressure medications do not exist in isolation. Certain pain relievers, some antidepressants, potassium supplements, and even particular over-the-counter cold remedies can interfere with or amplify the effect of what you are already taking. Any physician who takes your health seriously will welcome these questions, not resist them. If a doctor dismisses you for raising any of the five, that response tells you something important about whether that relationship is genuinely serving your health. Let me close where I opened, with Walter Higgins, the retired shop teacher from outside Tulsa, who took a pill for 3 years without understanding a single thing about it. After his daughter encouraged him to ask the 5 questions at his next appointment, his doctor did not change his diagnosis. He changed the conversation. A medication review revealed his dose had never been reassessed since his original prescription 5 years earlier, despite 2 intervening hospital visits for unrelated issues that should have triggered a recheck. His dose was adjusted. Within a month, the afternoon fatigue he had quietly accepted as simply getting older had measurably lifted. His blood pressure remained well controlled. But now the number on the chart and the way Walter actually felt living with it finally matched. A blood pressure medication should help you live better. Not simply live longer on paper while quietly taking your energy, your balance, and your clarity in exchange. If that is the trade currently happening without your full knowledge, you have every right to question it, revisit it, and ask for something better. Here is your action plan. Not someday, starting at your very next appointment. Step 1. Before your next visit, write down the exact name of your blood pressure medication and which of the 3 classes it belongs to: calcium channel blocker, ARB, or ACE inhibitor. If you are not certain which class your medication falls into, that is itself useful information to bring to the appointment. Step 2. Ask your doctor directly why this specific medication was chosen for you over the other 2 classes. Request a specific, personal answer rather than a general one. Step 3. Request that your standing blood pressure be measured at this visit, in addition to your seated reading. If you have experienced any dizziness on standing, mention it explicitly and ask for orthostatic vitals to be documented. Step 4. If you are on Losartan or Lisinopril, ask when your potassium and kidney function were last checked. If it has been longer than 6 months, request these tests be scheduled before you leave the appointment. Step 5. If you have noticed swollen ankles, a persistent dry cough, or unusual fatigue since starting your medication, name these specifically as possible side effects, rather than separate, unrelated complaints. Ask whether an alternative within a different medication class might resolve them. Step 6. Ask whether your current blood pressure target is appropriate for your specific age and health profile, particularly if you are over 75 or have a history of falls. Request this conversation explicitly. It is rarely initiated without being asked for. Step 7. Write all 5 questions from this video on a single card or note on your phone, and bring it physically into the appointment room. A list in hand changes how a conversation unfolds far more reliably than questions held only in memory. If this video gave you something your doctor never had time to say, subscribe to Dr. Sam Sterling, leave a like, and tell me in the comments, which of the 6 things was new to you? I read every comment, and I will see you in the next one.